Good morning, ladies and gentlemen.
Good morning, Dr. Miller.
Good morning. I see there are 6 of you present. We'll give another 3 minutes and then we'll start. And we're going to be talking about transposition of the great arteries in about 3 minutes or so. I have to take it off. I'll take it off. Can you plug it in elsewhere, please? John. Plug it in elsewhere. Plug it in elsewhere. Use this for now. Good morning, ladies and gentlemen. I see there are 10 of you, and we're going to begin. Now we're going to be talking about transposition of the great arteries. Yesterday we were talking about tetralogy of Fallot, which is the commonest type of cyanotic congenital heart disease. But these patients, in fact, do not present with cyanosis in the early newborn period usually, unless the defect is very severe. In transposition of the great arteries, this is the commonest cause of babies appearing blue at birth. And in transposition of the great arteries, the aorta arises from the right ventricle anterior to and to the right of the pulmonary artery, which arises from the left ventricle. Are you hearing me all right? Are you hearing, ladies and gentlemen?
Yes, we are,
Yes,
Dr. Miller.
Doc.
Okay. If we look at this illustration here, on the left, the illustration on the left is the normal situation, and on the right, it's the situation with transposition of the great arteries. So on the left, in the normal situation, the right ventricle gives rise to the pulmonary artery, and this branches into right and left pulmonary arteries and into the pulmonary vascular bed, and oxygenated blood from the lungs will come back via the pulmonary veins into the left atrium and into the left ventricle and then into the aorta and the systemic circulation. In this situation with transposition of the great arteries, systemic venous blood comes back into the right atrium and into the right ventricle, and then goes into the aorta from the right ventricle. And into the ascending aorta, arch of the aorta, and the descending aorta. Oxygenated blood. Let's continue the journey of systemic venous blood. So it goes to right ventricle, aorta, aortic arch and descending aorta, to the systemic venous system, and comes back into the right atrium. Then again into the right ventricle, aorta, and so on. Blood, oxygenated blood coming back from the pulmonary circulation, enters the left atrium via the pulmonary veins, and then goes to the left ventricle and into the pulmonary artery branches, the pulmonary vascular bed, and back into the left atrium. So in the normal heart, there is a single circulation in series. In transposition of the great arteries, there are two circulations in parallel, as we've illustrated. Systemic venous blood into right ventricle, into aorta, back into systemic circulation, systemic venous blood, right ventricle. And on the left side, pulmonary veins enter the left atrium, oxygenated blood goes to the left ventricle, into the pulmonary artery branches and the pulmonary vasculature, back into the left atrium. So there are, in fact, two parallel circulations. Obviously, this is not going to be compatible with life. In utero, there are communications which exist, and the communications which exist are the patent foramen ovale and the patent ductus arteriosus. Let's go back. Survival is going to depend on communication between these parallel circulations. And these communications exist in utero. After birth, the cyanosis occurs. because particularly when the ductus closes and the newborn becomes hypoxic and acidotic. And there is cardiac failure in the newborn period. When the ductus closes, there is severe hypoxia, cyanosis, and death will ensue if there is no other communication between these two parallel circulations. Are you with me? Do you understand the situation? Would you like me to go over it? Understood? You don't have to give your name, just say if you want it said again. And if after the lecture you want any further explanation, I will try to give it. Hello?
Yeah, understood, Doc.
Your understanding? So if after there is no communication between pulmonary and systemic circulation, that is not a situation which is compatible with life. In complex transposition, after birth, there may be communications that exist. For example, at the level of an atrial septal defect or by persistent patency of the ductus arteriosus, PDA, and by a ventricular septal defect, which will allow mixing at the level of the ventricle. In transposition of the great arteries, the treatment is going to involve maintaining ductal patency by the infusion, the intravenous infusion of prostaglandins E1 in the early newborn period. So if a child is born in a not sophisticated facility in the country and you suspect there is transposition of the great arteries, then what you would do is begin an intravenous infusion of prostaglandin E1 in the early newborn period. And this is maintained while the patient is transported to a facility where further investigations and management can take place. And having transported the child to such a facility, what would happen is the establishment of the diagnosis, and if transposition of the great artery is the diagnosis is sustained, then a balloon atrial septostomy is done, which allows further mixing of blood at atrial level, and the child is maintained on this until definitive surgery. So if we go to the next slide. In the situation of a balloon atrial septostomy, a balloon catheter is introduced in the femoral vein and into the IVC, inferior vena cava, and into the left atrium, and is pushed through the foramen ovale it's introduced into the right atrium and then across the foramen ovale into the left atrium. Once in the left atrium, the balloon is distended, usually with contrast medium. And then the balloon is forcibly pulled back from the left atrium into the right atrium. And where that big white arrow is shown in the diagram at the upper right. And below there, that shows the distended balloon, atrial, used for atrial septostomy. So in fact, what you have done using this balloon atrial septostomy is to create a communication between the left atrium and the right atrium without having to make an incision into the patient's chest. Are you with me? Do you understand what we've done? If you're okay or you'd like to repeat.
Doc, you can say that one more time.
Okay. So we would transport this child. We transport this child with an infusion of prostaglandin to maintain the patency of the ductus arteriosus until the child can be admitted to a facility where there are further investigations that can be done to establish the diagnosis. And having established the diagnosis by echocardiogram, chest X-ray, and ECG, there would be a balloon atrial septostomy performed. In the balloon atrial septostomy, a collapsed balloon catheter is introduced through the femoral vein into the inferior vena cava, into the right atrium, and it is pushed across the foramen ovale, which you see in that upper right diagram, into the left atrium. Once a balloon is in the left atrium, it is distended with contrast medium, and then it is rapidly and forcibly pulled back through the foramen ovale, and it creates a septal defect, which allows communication between the systemic circulation with deoxygenated blood and the situation and the left atrial blood, which contains oxygenated blood coming back via the pulmonary veins. So you have therefore established a communication between the two atria without having to do a surgical incision in this baby's chest. And then subsequently, go ahead.
Doc.
Somebody asking?
Doc.
Yes.
The purpose of using contrast medium is just solely for visualization.
That's mainly for it. Yes. So it shows you when the balloon is distended. Okay.
Okay, thanks. Thanks.
So you've now created an atrial septal defect. And then after some weeks and months, more definitive surgery would be performed, and they would perform an arterial switch operation, which put simplistically means that the pulmonary artery and aorta are divided, and the aorta is placed to come off the left ventricle and the pulmonary artery from the right ventricle. And that's the arterial switch operation, which is usually done in the early months of life. Other operations may be done depending on what other existing defects there are. So that is a really simplified explanation of how transposition of the great arteries is managed. Are you okay?
Yes, Doc.
That's not a very confident yes. Is that you, Lloyd?
Yeah, could you just go over that one more time, please?
Okay. So the problem is with transposition of the great arteries is that we have the aorta coming off from the right ventricle, and we have the pulmonary artery coming off from the left ventricle. So you divide these two vessels and you place the aorta to come off the left ventricle and the pulmonary artery to come off from the right ventricle. So you have corrected the switch, so to speak, corrected the transposition. There are other complexities in transposition of the great arteries, but we're not going to go into that today. Transposition of the great arteries. I'm not quite sure. We keep getting an intermittent echo. Have you turned off your, I'm not quite sure where. Have you muted your mics? Or are some of the mics open?
Yes, Doc, they're muted now.
They're muted now. Okay. So that's transposition of the great arteries. And you should remember, in fact, transposition of the great arteries is the commonest defect, congenital heart defect, leading to cyanosis in the newborn period. Whereas tetralogy of Fallot statistically is the most common cyanotic congenital heart disease. But these patients, as we had mentioned yesterday, do not usually present in cardiac failure in the early newborn period, but at some time after birth, either weeks or months after birth. Shall we press on, or do you want any further explanation, or are there any other questions? Okay, let's continue. Now we're going to look at other conditions, other types of cyanotic congenital heart disease. And we're going to look mainly at the diagrams. This is truncus arteriosus. And unfortunately, my arrow is not working. I'll try again today. Do you see an arrow in LV? Do you see a hand in LV?
No, we
No?
don't.
Okay. I'll have to get in touch with the IT people about this. But if you see that diagram, IVC is inferior vena cava, right RA stands for right atrium, SVC for superior vena cava, and right ventricle for RV is short for right ventricle, LV short for left ventricle. And in this illustration, we see that there is a ventricular septal defect which allows blood to flow both from the right ventricle and the left ventricle into a common trunk from which will arise the aorta and the pulmonary artery. So it means that deoxygenated blood from the right ventricle mixes with oxygenated blood from the left ventricle in this common trunk, and the patient is cyanosed. So there's desaturated blood provided to the systemic circulation. In the case of tricuspid atresia, do you see that circle there, which is circling, in fact, the tricuspid valve, and there is no opening between the right atrium and the right ventricle in this diagram. And blood, therefore, coming back in the systemic venous system, goes across an atrioseptal defect from right atrium to left atrium to the left ventricle, and in fact will mix at that point with blood coming back from the left, from the pulmonary circulation. So there's deoxygenated or desaturated blood going into the aorta. And blood is supplied to the pulmonary artery via a ventricular septal defect, which is 3 in the diagram. This is the condition of total anomalous pulmonary venous return. Situation, what is happening? Pulmonary venous, somebody's mic is on again. Total anomalous pulmonary venous return means that the pulmonary venous blood, in fact, instead of going into the left atrium, which is the normal situation, will join with pulmonary venous blood from the right side and the left side and enter into the right atrium at some point. Either at the level of the superior vena cava or at the level of the right atrium or into the coronary sinus. And usually there is an enlarged right atrium. So there is mixing of blood, oxygenated blood from the pulmonary system, mixing with deoxygenated blood in the right atrium. And there's deoxygenated blood, therefore, going into the left atrium, to the left ventricle, to the aorta, and the systemic circulation. And these patients are cyanosed because of the mixing of these two types of circulation. When there is obstruction at the point where the anomalous venous return enters the right atrium, it causes a lot of pulmonary venous congestion, and in fact these patients usually present earlier and need more aggressive treatment. So that's total anomalous pulmonary venous return. There is also partial anomalous pulmonary venous return, where the venous return may come from one side, the right side, or the left side, into the left atrium. And these patients are not as sick or as cyanosed as those with total anomalous pulmonary venous return. Then there is pulmonary atresia. And in the diagram shown, you see that there is an atrioseptal defect, and the right ventricle is in fact smaller than the left ventricle, and there is no passage of blood from the right ventricle across the pulmonary valve into the lungs. And in this situation here, we have an atrioseptal defect, So blood from the right atrium goes across this defect into the left atrium, and there is mixing of blood. And blood is usually supplied to the pulmonary arteries via arteries which come off the aorta. And these patients are cyanosed. And we can see that there is no ability for blood to pass from the right ventricle into the pulmonary artery. And the right ventricle is usually very thick and has a small volume capacity. Then there is this condition called hypoplastic left heart syndrome. There is supposed to be a P after the PO, hypoplastic left heart syndrome, which is an underdevelopment of the left side of the heart. And if you compare these two illustrations here, you will see that the mitral valve is underdeveloped, either severely stenosed or not developed at all. If you compare the size of the left ventricle in the normal heart with the diagram on the right side, you will see that the left ventricular size is considerably smaller. In addition to the aorta and the ascending aorta and arch of the aorta are also underdeveloped. And these patients, this is a lethal condition. Patients who are born with this condition in our part of the woods are usually condemned to die. What happens, they appear all right for the first few hours of life, and then when the ductus closes, they become hypotensive and they become cyanosed, and unless there are facilities for doing the staged operations which are necessary to correct hypoplastic left heart syndrome, these patients will not survive. In some countries, for example, in Cuba and in some European countries, if this is recognized in utero, the termination of pregnancy is offered. I'm not suggesting that this is in fact the management, but this is what happens in practice in some countries. We had some visits to Cuba some years ago, and we noticed when they presented the findings on congenital heart disease that there was no mention about hypoplastic left heart syndrome. And we were informed that these pregnancies were usually terminated, or termination was offered. So that's hypoplastic left heart syndrome. And a child who is born in our part of the world, unless the parents themselves have insurance or have wealth, they are not able to access the few facilities overseas where these conditions are in fact managed. And it usually requires 3 or 4 surgeries and very prolonged stay in intensive care units. So if the parents or guardians are not able to fully fund this, it's not available. Okay. Do you understand the basic problems here? Are you understanding the reason why these conditions are cyanotic? And in the case of the hyperplastic left heart syndrome, the ductus arteriosus, in fact, provides blood to the pulmonary circulation as well as to the descending aorta. Any questions? Okay, so we're now at 11 a.m. and I think this lecture goes on until 12:30. Is that correct? I think they're supposed to be 2 hours. Are you hearing me? Can you communicate, please?
Yes, Doc, hearing you.
Are there any gentlemen there? I'd like to hear a male voice.
Yes, Doc.
Okay. I don't expect that you're going to understand fully what has been said, but these illustrations are, I think, should be on your OUR VLE site. And I don't know if you are familiar with Heart's pediatric cardiology, which I know they have in the library, which can explain the pathophysiology of these types of cyanotic heart disease. If you would like me to repeat anything, say so now, or you can contact me by email. And at this particular time, we're going to go to cardiac failure, unless there is some request for a repeat.
No, Doc, I don't think so.
Don't think so. All right. You're either totally confused or absolutely brilliant. Okay. So right now, we're going to stop sharing this set of slides and go to I hope we have it here. Coarctation of the aorta. Okay, we're going to talk about cardiac failure, and for the first few slides, I will reintroduce or remind you about certain terms which I think had been introduced to you from the preclinical years, and which, in fact, if you're in the final year, you would have been utilizing in your clinical rotations. Oxygen delivery is equal to the oxygen content times the cardiac output. And yesterday we looked at the calculation of oxygen content, which is shown below, where you use the oxygen saturation times the hemoglobin times that constant of 1.39 mils per liter, which means that you have to multiply by 10, and that's at 100% saturation. So that will give you the oxygen content. And the cardiac output, as you can remember from your preclinical years, will be the heart rate times the stroke volume. Other terms which I would recommend that you read about in your reading on the subject which we're talking about today is stroke volume, which depends on the preload, afterload, and contractility or inotropic state of the ventricle. The preload is a load before the contraction, and it equates to the filling volume of the heart. And the afterload is the load after contraction of the heart and represents the resistance the ventricles face on ejection of blood, for example, the blood pressure. The contractility or inotropic state is the efficiency and force of contraction of the heart muscle. Then there is myocardial oxygen demand, which increases with the heart rate, with wall stress, either afterload and or preload, and also once there is increase in contractility. This leads to increase in myocardial oxygen demand. And wall stress is equal to the pressure in the chamber times the radius over 2 times the wall thickness. So the wall stress, there is an inverse relationship to the wall thickness. So when there is hypertrophy of the muscle, it tends to reduce the wall stress. Myocardial hypertrophy in response to a pressure overload acutely increases wall stress and leads to the replication of myofibrils in parallel and thickening of the individual myocytes. And this results in concentric hypertrophy. So pressure overload leads to concentric hypertrophy with marked thickening of the muscle fibers and the muscle layer. And in contrast to volume overload, in which you get replication of the sarcomeres in series and elongation of the myocytes and dilatation of the chamber. And this leads to a moderate increase in systemic stress. And this leads to eccentric hypertrophy. So conditions like the left to right shunts will lead to eccentric hypertrophy. Conditions like aortic stenosis lead to concentric hypertrophy. Cardiac failure is a state in which there is inadequate cardiac output to meet the body's metabolic needs at normal physiologic venous pressures. And this may be due to primary abnormality of the myocardium or to excessive workload. For example, in a patient who has a ventricular septal defect or aortic valve regurgitation. In acute cardiac failure, there is acute uncoupling between the compensatory mechanisms and the decreased myocardial function. And this leads to homeostatic imbalance and overt symptoms. In chronic cardiac failure, there is cardiac pump dysfunction, and there is activation of a number of compensatory responses that we will mention that ultimately lead to silent and progressive deterioration of myocardial function. In which case, there is poor response to the compensatory mechanisms and poor response to the medications which are used for the treatment of cardiac failure. And there is usually fibrosis of the myocardium. We're not going to talk much about shock today. Usually this is covered in the management of dehydration and gastroenteritis. But shock is an acute circulatory dysfunction with completely overwhelmed physiological compensatory mechanisms. And if there is not rapid intervention, death will ensue. The cardiac failure compensatory mechanisms are listed there, and I think that you will probably remember your lectures in the preclinical years, and I'm sure that in all the disciplines through which you have rotated so far, you have met patients in cardiac failure, whether it's in obstetrics or surgical or adult medicine. The compensatory mechanisms include increased heart rate, the Frank-Starling mechanism, sympathetic nervous system activation, which is a major part of the compensatory mechanisms, increase in 2,3-DPG, increase in the natriuretic peptides, and myocardial hypertrophy. The changes in the hemodynamics will include increase in heart rate, increase in the volume, the ventricular end-diastolic volume, and increase in the end-diastolic ventricular pressure. Also increase in atrial pressure and increase in the systemic vascular resistance. And there is also a decrease in systemic blood flow. This is not new stuff. You met it probably 2-3 years ago, and it's probably been mentioned in the management of patients through your various rotations. The Starling's law of the heart states that the force of ventricular contraction and the volume of blood which is ejected at contraction will increase directly with an increase in the initial volume of the ventricle at the time of systole. That's an increase in end-diastolic volume. So if we look here, we see stroke volume on the y-axis, end-diastolic volume on the horizontal axis. And between these two arrows would be the normal range. So with an increase in end-diastolic volume, we can see that the with an increase in end diastolic volume, the stroke volume is going to increase from the normal range to the maximum capacity to produce the stroke volume. Beyond that maximum capacity, there's no further increase, and there may be theoretically decrease in stroke volume. This should be familiar to you, and I'm sure you met in the preclinical lectures. Then if we look at the family of ventricular function curves, cardiac output is on the y-axis and atrial pressure or preload is on the horizontal axis. Sympathetic stimulation increases heart rate and increases contractility, so that for any atrial pressure or preload, increase in cardiac contractility and increase in heart rate will lead to an increase in cardiac output. Let us continue. The compensatory mechanisms, the effects of the catecholamines cause an increase in contractility with increase in cardiac output and increase in blood pressure. That's sympathetic nervous system stimulation, leading to increased cardiac output and increase in blood pressure. The sympathetic stimulation also increases heart rate, and in fact, it causes a decrease in renal perfusion, renin production, angiotensin II and aldosterone, systemic vasoconstriction, sodium and water retention, and increase in cardiac output. So let's go to the next slide. And I would encourage you to commit this diagram to memory because it outlines a lot of things which happen in the cardiac compensatory mechanisms. So we have, in the situation of cardiac failure, angiotensinogen being converted to angiotensin 1, and this is facilitated by renin. And angiotensin 1 is converted to angiotensin 2 via the converting enzyme. And this is the point at which the ACE inhibitors will work. Now, angiotensin 2 is itself a very potent constrictor of vascular smooth muscles, and in fact leads to an increase in the afterload. And angiotensin 2 itself stimulates the production of aldosterone and causes increase in water and sodium retention by the kidneys and increase in preload. And this explains a lot of what happens in the compensatory mechanisms during cardiac failure. You should memorize this diagram. (2,3-diphosphoglycerate) is increased in cardiac failure, and this increase results in a shift to the right of the oxygen dissociation curve, which facilitates oxygen being unloaded to the tissues. Because during cardiac failure, there's an increased oxygen demand. Then there are the natriuretic peptides, particularly atrial natriuretic peptide, ANP, which is released from the atrial wall in response to atrial stretch, and which causes a urinary loss of sodium and water. And ANP is also a vasodilator, and it reduces tachycardia. So it's a naturally occurring control for the effects of the sympathetic nervous system, which is very prominent in patients in cardiac failure. There are also other natriuretic peptides such as BNP, released from the ventricular wall during cardiac failure. And in fact, BNP can actually be measured at the bedside. For example, you may have a patient who comes into the accident and emergency unit who is in cardiopulmonary distress, and you want to find out, is this pulmonary, or is this cardiac in origin, or is it a mixture? And you can actually measure BNP, which will give an idea of what type of condition is causing the respiratory distress. This peptide can be measured, provided, in fact, the patients are able to afford it. Unfortunately, in some instances, it will not be done in the emergency unit because of economic considerations. And BNP is also used in the measurement of the degree of cardiac failure. There may be patients who are actually waiting for heart transplants, and the BNP, if measured and shows an increase in the level, will indicate a worsening in cardiac function and would accelerate the transplantation, heart transplantation. In the normal state, inhibitory impulses from arterial and cardiac and pulmonary nerves control sympathetic flow. And it is the parasympathetic outflow which is dominant in the normal state. In cardiac failure, inhibitory impulses decrease and excitatory impulses increase, and the sympathetic nervous system is stimulated. So in cardiac failure, the sympathetic nervous system is dominant, whereas in the normal steady state, the parasympathetic system is blunted, is dominant. Parasympathetic system dominates in the normal state and is blunted when there is cardiac failure. Other compensatory mechanisms, norepinephrine is released in cardiac failure, and with endothelin 1 and vasopressin cause blood pressure to increase, which leads to vasoconstriction, leads to increase in afterload, increase in also this stimulation leads to cyclic AMP being increased, which causes influx of calcium into the myocytes and increases the contractility of the heart muscle and increases the cardiac output. Therefore, the sympathetic nervous system is really a key factor in the compensation for cardiac failure. And the sympathetic nervous system also increases the heart rate and leads to decreased renal perfusion, which activates the renin-angiotensin mechanism, which we went over in that diagram. Myocardial hypertrophy. The myocytes respond to changes in loading conditions in cardiac failure by hypertrophy. Angiotensin II leads to hypertrophy of the myocytes, and aldosterone leads to the deposition of collagen in the myocardium and leads to the fibrosis of the myocardium and end-stage renal failure. The harmful effects of the sympathetic stimulation then are myocyte injury and necrosis. There is accelerated apoptosis, which is a normal process of programmed cell death. Sympathetic nervous system stimulation increases the heart rate, the contractility, and increases wall stress and leads to increase in oxygen consumption. Hypertrophy also leads to oxygen demand increase. It leads to damage to the heart muscle and the deposition of fibrosis and a decrease in cardiac output. So in summary, the sympathetic nervous system leads to improvement in the acute stage, but in the chronic stage, it leads to decline in cardiac function. And if continued for long, leads to end-stage cardiac failure. This is not new material for you, but I think it's worth your revising, because anytime you meet a patient in cardiac failure, and that occurs in almost all of the disciplines, then if you're going to understand the findings, the physical findings, and the treatment which would be necessary for these patients, you've got to go back to basic pathophysiology. Are there any questions at this time, or if you would like to send an email or ask for any references as regards those previous slides which we've looked at? Any questions, time? No?
No, Doc.
Yes?
Good so far, Doc.
Okay. Please remember in your revision of the topic to go back to the pathophysiology. And I always advise the students, you should never get rid of your anatomy books, and you should never get rid of your physiology books. The biochemistry changes, but those books should be with you all the time. And if anything, you can upgrade and buy new editions. Now let's look at the causes of cardiac failure according to the categories. Increased increased blood volume is a cause of cardiac failure, and this occurs in aortic incompetence, mitral incompetence, tricuspid incompetence, and with the left to right shunts, which we spoke about before. And sometimes we overtransfuse patients or give them large volumes of fluid and increase the blood volume, and that may lead to cardiac failure. The other category of causes for cardiac failure include pressure overload, which will occur with aortic stenosis, hypertrophic obstructive cardiomyopathy or HOCM, coarctation of the aorta, and hypertension, which all may result in cardiac failure. Other causes would be under the heading of myocardial dysfunction. For example, the cardiomyopathies and in the myocarditis, which may occur in different conditions, and also with the dysrhythmias. And there may be toxic causes of the myocardial dysfunction, sometimes as a result of the medications which we use for some malignancies, for example, adriamycin. In disorders, if the ventricles cannot fill adequately, then the adequate cardiac output cannot be maintained. And then there are increased metabolic demands, as will occur with patients who have hypothyroidism. The other causes we can look at according to the age groups. There may be fetal or congenital causes, which would include supraventricular tachycardia in the fetal state, or erythroblastosis fetalis, which usually follows on what condition? Under what condition would you get this erythroblastosis fetalis? With pale edematous fetuses. We test mothers for this all the time. Yes, what you say?
Hemolytic anemia of the newborn.
Yes, and in fact, Rh incompatibility may result in erythroblastosis fetalis, as well as AV malformations, which would increase the work of the heart. How do you know how supraventricular tachycardias would be managed? If you've got a fetus with supraventricular tachycardias, what do you think can be done? Usually what is done is digoxin is given to the mother, and in many instances that will correct the supraventricular tachycardia. What is going to be done for the child with erythroblastosis fetalis? Do you know what can be done in utero?
Is that we can give the mother a program?
That's after birth,
Or after birth?
to prevent it occurring in a subsequent pregnancy. But when you have a pregnancy in which this problem already exists, do you know what can be done? You can do intrauterine transfusions. Okay? And the AV malformations will depend on how severe they are and, in fact, how near to delivery the fetus is. Then we look at cardiac failure in the first week of life. Sorry, let's go back. And these are the duct-dependent lesions. When you have a duct-dependent lesion, what it means is that the flow of blood into the aorta or into the pulmonary artery or into both aorta and pulmonary artery depend on the flow of blood through the ductus arteriosus. And when the ductus closes after birth, these patients get into problems. For example, the hypoplastic left heart syndrome, and patients who have severe aortic stenosis or severe coarctation of the aorta. And there are other non-duct dependent lesions like total anomalous pulmonary venous return, and the AV malformations, and myocardial dysfunction, which is seen in the first week. And this is a condition which occurs in children who have perinatal asphyxia, and also supraventricular tachycardias may occur in the first week of life, and sepsis could be a cause of cardiac failure in the first week of life as well. During infancy, continuing to look at the age groups, the causes of cardiac failure include obstructive lesions such as severe coarctation or severe aortic stenosis. And it is also seen in the left to right shunts, and also in the mixing lesions, by which we mean these patients are cyanosed, as well as in cardiac failure. And these lesions include total anomalous pulmonary venous return, transposition of the great arteries, and truncus arteriosus. And then there are conditions due to diseases or difficulties with the myocardium or the pericardium. And these conditions include supraventricular tachycardias, myocarditis of different types, the cardiomyopathies, and a condition that we call purulent pericarditis. This condition of purulent pericarditis usually occurs when there's a bacterial pneumonia, such as a staphylococcal pneumonia. And what happens is that pus accumulates in the pericardial cavity. And the management of this condition would include, must include the removal of this pus from the pericardial cavity quite vigorously, and appropriate antibiotic treatment. It's seen particularly in the purulent pneumonia that you get with staphylococcal organisms. Then in the adolescent and child, in addition to the congenital lesions, we have certain acquired conditions like myocarditis of different etiologies, cardiomyopathy, AIDS, and at least 50% of the patients who have AIDS will show on investigation some myocardial dysfunction. And some of them, in fact, go into cardiac failure and have to be treated for cardiac failure in addition to the medication for AIDS. Then there are cardiotoxic drugs that I've mentioned, like adriamycin. And any patient who goes on adriamycin, and we use this for malignancies in children, they need to be followed over time to see what the function of the myocardium has been. And even in appropriate dosage being used, some of these patients over time get myocardial dysfunction. And if you have, for example, an adolescent patient in cardiac failure with no known or demonstrable structural defect of the heart or other cause, one should suspect substance abuse, like illicit drugs, cocaine, and crack cocaine use. Then we have the factors which complicate the congenital lesions, cardiac lesions. Anemia, and if the patient is anemic, you have to manage that, find out the cause, and give the appropriate treatment. Infective endocarditis may also lead to cardiac failure, and it is not uncommon after cardiac surgery for there to be some element of cardiac failure as well. And then there's myocardial deterioration, which occurs in long-standing patients who have cyanotic lesions. This is the cardiac failure, the New York classification, class 1 to 4, which is used much more frequently in the adults, in adult cardiology, and is of use particularly in patients, pediatric patients who are awaiting heart transplantation. Let's think of the clinical manifestations. Just a moment, let me go back to the history. Sorry. The history. In small infants, feeding difficulties are seen early in cardiac failure. And the difficulties which they exhibit is they get shortness of breath on feeding, on sucking at the breast or the bottle, and they tend to have frequent pauses during sucking. And what happens is that the duration of feeding usually is extended, but the total volume of feed being taken in is usually reduced. So feeding difficulties are seen quite early. There's shortness of breath, which is worse on feeding, and this exertion on feeding is equivalent to the exertional dyspnea which adults or older children have when they go upstairs or climb up the hill. And the respiratory symptoms predominate in small infants. They tend to sweat a lot, especially during feeding. And if they're in cardiac failure for a period of time, when they usually have inadequate intake of milk and calories, they show poor weight gain and poor linear growth. In the older children, like adults, they may show fatigue, exertional dyspnea, orthopnea, and edema of the face and legs. Just a moment. The clinical manifestations, tachycardia, which occurs frequently in cardiac failure, except in the situation where you have a primary bradycardia or complete heart block. There is systemic venous congestion because of the retention of sodium and water, and this leads to increase in the liver size, which also becomes tender in the acute stage, increase in the jugular venous pressure, and edema. And it should be noted that in small babies, in the newborns and in infancy, edema tends to be in the face primarily and in the periorbital region, unlike the older children and the adults, where edema tends to be dependent early on. There may also be accumulations of fluid in certain cavities, like pleural effusions, may occur in severe cardiac failure, as well as ascites. And this is secondary to the retention of sodium and water. Pulmonary venous congestion also occurs and the clinical manifestations would be increase in the respiratory rate, retractions, suprasternal, intercostal, subcostal retractions, flaring of the ali nasi, grunting respirations, wheezing may occur, and wheezing can occur in cardiac failure at any age. And sometimes what we notice, in fact, is that babies are admitted with a diagnosis of bronchiolitis, and then over time it becomes apparent that it's not bronchiolitis, but they have cardiac failure, and it is the edema of the airways which leads to the wheezing. Crepitations and crackles may also be heard, and there's pulmonary edema, and they may become irritable because of a low oxygen content. Low cardiac output leads to tiredness, pallor, sweating, cool extremities, and a low pulse volume, although in certain conditions, for example, in patent ductus arteriosus or in aortic incompetence, the pulse volume may remain high. And there is decreased capillary refill, which you test for every time when you examine the cardiovascular system. Volume overload because of sodium and water retention may lead to cardiac enlargement, and this may result in a gallop rhythm. And because the ventricles become distended and enlarged, there's stretching of the mitral valve ring, and this may cause mitral regurgitation. So a regurgitant murmur suggesting mitral incompetence can occur with cardiac failure without there being a structural problem with the valve itself. The urine output is usually decreased, and I'm not quite sure if you've done your rotations in the intensive care unit, but every hour at least, and sometimes more frequently, the urine output is charted, and this gives an indication of what the cardiac output is like. And there is cardiac failure, there may be growth failure and weight loss if cardiac failure is continued. So in the evaluation of a cardiac failure patient, the history is important. The physical examination, I'm sure that you will have the opportunity to see patients in cardiac failure. Cardiac failure occurs quite often in pediatrics. And the investigations which are usually done are chest X-ray, ECG, 2D echocardiogram, pulse oximetry, blood gases, and an oxygen challenge. Urea and electrolytes, because if there are abnormalities of urea and electrolytes, you may not want to use certain medications, for example, digoxin. CBC, urinalysis, blood culture, and serum calcium may also be done. And the blood glucose is particularly important in the young infants and in the newborns. And there are other investigations which may be indicated by the history and physical examination. As far as cardiac failure is confirmed, it's important to identify and treat the underlying cause, not in the chronological order shown here. Because if you get a patient in acute cardiac failure, you need to get on and give treatment and then do the investigations and identify underlying causes. If there are aggravating factors such as anemia, sepsis, hypertension, those also need to be addressed. And the management of cardiac failure itself may be non-pharmacological or pharmacological. Non-pharmacological would include, in the severe case, the patient would be confined to bed and be propped up to reduce the return of venous blood to the heart. Oxygen may be given and fluid is restricted. Salt restriction is also advised, but as far as the children are concerned, we don't do severe salt restriction because the diet becomes unpalatable and will not be taken by the smaller children. And they need adequate calories. And in many cases, adequate calories will mean greater than the calories required for the weight and height of the patient. For example, a baby who might be feeding on milk mainly may have a requirement of 100 kilocalories per kilogram per day, and this may increase, maybe increase to 150 or 180 kilocalories per kilogram per day in order to provide the extra calories which are required by the patient in cardiac failure and to ensure that growth will occur. Those patients who are ambulant, who are not as severe, we say no added salt. And in the adults, they are usually encouraged to have mild exercise. We very rarely have to encourage exercise in the small babies and in the younger children. In fact, the problem that we have is trying to prevent them from chasing around. The cardiac failure treatment will involve pharmacological treatment, which will include diuretics. And Lasix is one of the diuretics that we use primarily. Vasodilators and ACE inhibitors. And the ACE inhibitors are particularly useful in when you have volume overload situations. Beta-adrenergic blockade, although used frequently in cardiac failure management in adults, has limited usage in the pediatric age group because there is a sensitivity to the negative inotropic effects when you use the beta blockers. Digoxin is used, the passion for using digoxin comes and goes over the years. And in some instances, when we've used all the other medications, we may add digoxin. And then there are the beta agonists, which we use in the intensive care unit setting. And this would include butamine, dopamine, isoprenaline, and adrenaline. Now, there is a presentation on your OUR-VLE called the drug treatment of cardiac failure in children. And I would encourage you to download this and to commit most of what is written there to memory. The medications which are used quite frequently. You need to know what their effects are and their contraindications and the complications which occur with them. We don't have enough time to go into the pharmacology of this all. And are there any questions?
No.
It's all familiar stuff, I'm sure, but you need to know the basics. Any questions? I see somebody hands. Someone
Oh,
hands.
Doc, I said no questions. I just said it's familiar.
Yes. Well, make sure that you commit a lot of this stuff to memory. It's important. I'm going to give you about 2 minutes break, and then we'll continue with rheumatic fever and rheumatic heart disease. What happens after 12:30 for you?
We go
What
to our
is on your
specific
schedule?
site.
I'm sorry?
We have to go to prepare to leave to go to our specific site by 2.
Okay. All right. I'm going to give you about 3 minutes, and we'll go through the handouts on rheumatic fever and rheumatic heart disease.
Okay, Doc.
We're going to talk about rheumatic fever and rheumatic heart disease. No. Again, I think a lot of this should be revision for you. I would expect that you have had some lectures on this before. Have you? From a clinical point of view or a pathological point of view? You've had lectures on this before, haven't you? Ladies and
Yeah, I think in
gentlemen.
third year. In pre-clinical.
In the third year? Was it from pathology
Third
or
year, I mean.
was it clinical?
We did pathology in fourth year, so, and we had to cover review this.
You did the pathology. Okay. All right. Have you met patients with rheumatic fever and rheumatic heart disease?
No.
Yes. Well, in fact, things have changed quite a lot. These conditions don't occur as frequently as they used to. And rheumatic fever can be considered to be a multisystem inflammatory disease that follows upper respiratory infections with group A beta hemolytic streptococci in some patients. And rheumatic heart disease is the structural and functional changes that occur in the heart valves as a result of rheumatic fever. The rheumatic fever, in fact, follows throat and not skin infections with group A beta hemolytic strep, and the incidence would be 0.3% or less in the endemic situation, and in the epidemic situation, up to 3% incidence may occur following untreated infections. And the common age group, the rheumatic fever occurs most commonly in the 5 to 15 age group, and there's an overall equal sex incidence. It occurs particularly in patients of Polynesian descent and particularly people living under poor socioeconomic conditions with overcrowding and poor healthcare facilities. These conditions will increase the incidence. The prevalence in the USA fell from about 5 to 10 per thousand in the early 1900s to less than 0.5 per thousand in recent times. In the 1980s, there were a number of outbreaks which occurred in certain states in America, and the exact cause of this hasn't been found, but it's been suggested that there were more virulent organisms circulating at that time. So the recent outbreaks were related to the emergence of more virulent strains, and there have been continued outbreaks in military recruits, and the United States Army has programs for preventing the spread of streptococcal infection in military recruits. These are young people living in close quarters. The etiological agent is the group A beta hemolytic strep. The host is the human, and the mechanism is not fully worked out. This is an electron microscope picture of the streptococci occurring in chains, which you may be familiar with. And the group A beta hemolytic strep have a characteristic hemolysis pattern on appropriate blood agar, which is shown here, and I'm sure all of you have had the opportunity of seeing these blood agar slides with a clear zone of hemolysis around the colonies. Invariably, you're shown this in microbiology. This is a slide which looks at the structure of the group A beta hemolytic strep, showing the capsule, outer capsule, the inner cell wall, peptidoglycan, the cytoplasmic membrane, and the inner cytoplasm. And it's proposed that the antigen of the outer protein cell wall of the strep induces antibody response in the victim, which results in autoimmune damage to heart valves, subcutaneous tissues, tendons, joints, and the basal ganglia of the brain in the case of chorea. The host is a human host, and there's a genetic predisposition with a higher recurrence rate of rheumatic fever in some families. And there may be allotypic markers on B lymphocytes, which are increased in rheumatic fever patients, and a higher prevalence of certain HLA antibodies in rheumatic fever patients. Just a moment, please. In rheumatic fever, there is an abnormal host response in just genetically susceptible individuals to those strep antibodies, which cross-react with the mammalian tissues. There tend to be heart-reactive antibodies in the sera of rheumatic fever patients and increased levels of antibodies to tropomyosin and myosin in rheumatic fever sera. The pathology involves the diffuse inflammation of connective tissue and vasculitis and resembles collagen vascular disease, but the agent is well defined, unlike the collagen vascular diseases. And the heart involvement is also well defined, unlike in the collagen vascular diseases. And rheumatic fever is preventable by appropriate treatment of strep infections, unlike the collagen vascular diseases. The pathology I'm sure you were introduced to in your third year with edema, perivascular infiltrates with chronic inflammatory cells, degeneration of collagen. Sorry? Hello? I'm sorry. Is somebody saying something? Or was just an echo?
Perhaps an echo.
Okay, degeneration of collagen and fibrinoid deposits, and Aschoff cells and Aschoff bodies. And the pathology for the heart involves inflammation of endocardium, myocardium, and pericardium. This looks at the myocardial Aschoff body with large elongated cells and large nuclei, some of which are multinucleated. Here we're looking at the mitral valve from inside the left atrium, and we can see a stenotic valve. It's narrow, it doesn't open adequately, and it doesn't close adequately. This is mitral stenosis, which tends to occur later after mitral incompetence, which is usually the earlier lesion. And this gives a fish mouth appearance to the valve with fused commissures and cusps which are thickened and calcified. The diagnosis, I'm sure you're familiar with Jones criteria. There are major manifestations and there are minor manifestations. You're familiar with these Jones criteria, are you?
Yes, doctor.
Okay, and the minor manifestations may be clinical, for example, fever and arthralgia, and may be laboratory with acute phase reactions which are non-specific for rheumatic fever, elevated ESR and C-reactive protein, and a prolongation of the PR interval on the ECG, which does not necessarily indicate that there is cardiac involvement. And in the diagnosis of rheumatic fever, one looks for the evidence of a recent group A beta hemolytic strep infection with elevated or rising ASO titers and a positive throat culture or rapid antigen test, which can be done at the bedside. Scarlet fever used to be in this evidence of a recent group A strep infection, but some of the features of scarlet fever may be confused with Kawasaki disease in the younger children and also in patients who have infectious mononucleosis as well, with sore throat and rash. So to make the diagnosis, you need the presence of two major or of one major and two minor manifestations. And if there is evidence of a recent group A beta hemolytic strep infection, such as an increase in the ASO titer, this may indicate the high probability of acute rheumatic fever. WHO has revised its criteria recently, well, not so recently, in 2003, and the revision has been particularly useful because it allows easier diagnosis of a recurrent attack of rheumatic fever in patients who have established rheumatic heart disease. We don't have to go through these findings when you have chronic rheumatic heart disease, or what we call indolent or insidious onset rheumatic carditis, nor do you require to go through the Jones criteria or the WHO criteria for when there's a patient with rheumatic chorea. The clinical manifestations will include a history of sore throat in about 70% of individuals. This may only be in about 20% of the children, and most of the patients will complain of fever with rheumatic fever. Symptoms: there may be chest pain, and the chest pain in acute rheumatic fever usually occurs because of acute pericarditis. And typically these patients experience a chest pain when lying supine, and it is precordial pain and retrosternal pain. And when the patient sits up and particularly leans forward, then that pain is reduced. And so the chest pain, which is had with acute rheumatic fever, usually indicates the presence of pericarditis. There may also be symptoms suggestive of cardiac failure, shortness of breath, edema, cough, orthopnea and palpitations. And then there are signs of valvulitis or the murmurs, which occur particularly with acute rheumatic fever. And if we look at this diagram here, we see the situation when there is mitral regurgitation because of acute rheumatic fever. You get an apical pansystolic murmur, which conducts to the axilla and conducts to below the left scapula. And in some of these patients, they also have a mid-diastolic murmur. The murmur of aortic regurgitation is a blowing early diastolic murmur at the base of the heart. And this is heard best with the diaphragm of the stethoscope, with the patient sitting upright and sitting forward, and when the diaphragm is used for auscultation. So if you look here, you see this early diastolic murmur, which tends to fade off towards systole. And many of these patients with aortic regurgitation may also have an ejection systolic murmur. But the typical murmur of aortic regurgitation is an early diastolic blowing murmur heard at the base of the heart. The clinical features presentation may also include a pericarditis, where there's a friction rub, there's distant heart sounds. If there's a significant effusion, nowadays we don't worry about increase in cardiac dullness, because the echocardiogram is much more useful in determining if there is a pericardial effusion. And there are findings on the ECG and the chest X-ray. Are you familiar with the findings on the ECG in pericarditis?
Yeah.
Anybody?
Yes. No.
Tell me about it.
The thing is, I don't.
Tell me about
Things I don't remember them right now.
it. Okay. All right. Just a minute. Just a minute. Go to pericarditis. There is a type of pain which we mentioned before. There may be a friction rub, which you hear on auscultation over the precordium. And on the ECG, in early pericarditis, you get an elevation of the ST segment in the first few days. And then there is a return of the ST segment to the normal level. And then the T wave becomes flattened and inverted, and may remain inverted for a period of time. If there is a significant pericardial effusion, then you may get generalized low voltage complexes. And when you listen to the patients with significant pericardial effusion, the heart sounds and murmurs sound very distant. Clinically, on examination, you may find the murmurs which we've mentioned. They may have fever and evidence of cardiac failure. And the cardiac failure, which is found in acute rheumatic fever, is secondary to the hemodynamic changes which occur with mitral and aortic incompetence. I would ask you to read about the clinical manifestations of the arthritis and the chorea. And this picture of subcutaneous nodules, which are painless, mobile lumps found over bony prominences such as the occiput and the elbows, the wrists and the knuckles, and over the knees and ankles. And these subcutaneous nodules usually are seen in patients who have cardiac involvement. This is a condition that we call erythema marginatum, which is shown here depicted in Caucasian type skin. And in people of color, it's very difficult to find these lesions. And I'm quite certain that none of you are going to find any patients with erythema marginatum. Erythema marginatum and subcutaneous nodules occur very infrequently in rheumatic fever nowadays. Remember, subcutaneous nodules and erythema marginatum are rare. And if you're using the minor manifestations of arthralgia, you can't use it if you're using major manifestations of arthritis. And the prolongation of the PR interval does not indicate that there's cardiac involvement. And all the minor lab manifestations which are done in rheumatic fever are non-specific. There is no specific single test which is going to tell you that the patient has acute rheumatic fever. The differential diagnosis, I'd ask you to read this slide. And these are the laboratory tests which we usually do when we suspect acute rheumatic fever. CBC, sickle test, ESR, ASO titer, and C-reactive protein. Particularly when there is cardiac involvement, we do the blood cultures to identify if there's infective endocarditis, and we do the throat culture, and we do ECGs, chest x-rays, and echocardiograms. The treatment of rheumatic fever. There is primary prophylaxis, which means that's a prevention of first attacks of rheumatic fever, which means that there is appropriate treatment of patients who present with sore throats. Ideally, what one should do, in fact, is to do a throat swab and hopefully obtain the result of the throat swab within a 48-hour period and give a 10-day course of antibiotics to eradicate the streptococci. In some situations, it takes such a long time to get the results back that it's not feasible to use this method, and a lot of times the clinicians will use their impression that a particular type of throat infection is secondary to a strep infection. But one should be aware that the typical features of a strep infection may be mimicked by patients who have adenoviral pharyngitis as well as infectious mononucleosis. The prevention of the first attacks then would mean prescribing a 10-day course of antibiotics for patients with a proven or suspected attack of streptococcal pharyngitis. The treatment also involves treatment of acute rheumatic fever, secondary prophylaxis, which has to be given to anybody with a diagnosis of rheumatic fever or rheumatic heart disease. And then there's management of rheumatic heart disease and continuing education of the patient and the family. Primary prophylaxis involves ideally giving a single injection of benzathine penicillin. When you give a single injection of benzathine penicillin, it lasts for over 3 weeks, which means that with a single injection, you have given the 10-day course of antibiotics required for the eradication of the streptococci in the throat. Antibiotics which ought not to be used for this purpose are tetracyclines, which don't work, trimethoprim sulfamethoxazole, or the Bactrim group of antibiotics, which sometimes the organism will become resistant to, nor do we use chloramphenicol. You may use as well the macrolides, a 10-day course of erythromycin, and also a 10-day course of clarithromycin. If you're using azithromycin, it is recommended that you use a 5-day course and not the 3-day course, which is sometimes recommended by the drug reps, because the 3-day course does not eradicate the streptococci all the time. In the management of rheumatic fever, these recommendations are to be noted. If you suspect a case of acute rheumatic fever, refer the suspected cases to hospital for diagnosis and treatment. In the management, various investigations will be done to see if you satisfy the criteria for diagnosis, and the treatment will involve eradicating the streptococci as shown, and for any patient who has only arthritis, in the pediatric setting, we would use only aspirin at the dosage shown for about 2 weeks, and then discontinued over another 2 weeks. For patients who have carditis, we recommend rest in bed or chair with continuing careful evaluation. For those with mild carditis, which means they are not in failure and they don't have any significant cardiac enlargement, then aspirins alone may be used for a period of about 6 weeks. If the patients have severe, moderate, or progressive carditis, for example, a large heart and they're in failure and they show evidence of pericardial involvement, then we recommend prednisone at the dose of about 2 milligrams per kilogram per day for about 2 weeks, and then that dosage is tapered gradually over the ensuing 4 weeks. Now, I know, in fact, that some of the adult physicians or the physicians who look after adult patients with rheumatic fever use prednisone once they make a diagnosis of rheumatic fever. But in pediatrics and some other physicians will use aspirin for the first treatment. And in fact, the studies have shown that at the end of a year, for those patients with mild and moderate carditis, it doesn't make any difference at the end of a year evaluating these patients whether you've used aspirin or other anti-inflammatory treatment. If there's cardiac failure, you give the appropriate treatment. Treatment of chorea is there's no specific treatment, you give emotional support. And in severe cases, you can use haloperidol or sodium valproate or Valium. And when the involuntary movements are very vigorous, sometimes we nurse these patients in a padded bed. Rheumatic fever treatment continued. Any patient who has had a diagnosis of rheumatic fever or rheumatic heart disease needs to be put on secondary prophylaxis to prevent recurrent infection and recurrent attacks of rheumatic fever. And the recommendations, and these are mainly WHO recommendations, and these are used by a lot of physicians, is to use intramuscular benzathine penicillin at the dosage shown, given every 28 days, or in some countries every 21 days. For example, in India, they tend to use every 21 days. If the patients have never had carditis, you can stop giving the secondary prophylaxis when they're about 18 years of age, provided 5 years have passed since the last attack of rheumatic fever. If you have young adults or late teenagers in high-risk occupations or situations, then you may continue into the early 20s. For patients who had high-healed carditis, in which the murmurs have disappeared and the echocardiogram findings have resolved, you may continue using the secondary prophylaxis for up to 25 years. And it is said that for patients with rheumatic heart disease, they should continue secondary prophylaxis for life. In effect, most physicians of adult patients will discontinue the secondary prophylaxis between 35 and 40 years of life, because it's very unusual for acute rheumatic fever to occur at that age. For patients with rheumatic fever for penicillin allergies, you can use sulfadiazine, 1 gram or 500 milligrams daily, depending on the size. Nowadays, it's difficult to get sulfadiazine, and in fact, I think it is being used for patients with AIDS. And what we do in the case where there are poor supplies of benzathine penicillin or patients are allergic, we use erythromycin 250 milligrams twice a day, every day. Rheumatic heart disease patients need cardiological evaluation and follow-up, and they need infective endocarditis prophylaxis if they're going to have dental work. They may also require surgical cardiac treatment for valve repair or replacement when indicated. And we need to continue to educate the patient, the family, and the public where funds allow. And WHO and other institutions have been involved in global prevention programs, some of which are active in other parts of the world at this time. We participated in the WHO prevention program in the 1980s, and this was prevention program was fully developed and passed over to the Ministry of Health, and is still an active program in the Ministry of Health in this country. I'm going to give you some references. If you want to do further reading, there is a WHO Technical Report Series 923, which you can download from Google. And the pictures which I had shown you come from the journal Pediatric Cardiology in the dates shown. This has been rather rapid. And if you have any questions, again, I'll be happy to answer if I can. Any questions now?
No, Doc, it was very clear.
Okay, so download the handouts, and if you need any special reading, refer to the reference, which has a lot of references to literature, which will explain certain things. And if you have any questions, you're invited to ask me to help. and I will do so if I can. Any questions now? No? Well, have a good afternoon.
Thank you, Doc. Same to you.
Okay. Bye-bye.